With the exception of your pathology lectures, it's all here. A review of the gross anatomy, the histology, as well as the embryology, radiology, and cross-sectional anatomy of the spleen is presented. The spleen, everything you always wanted to know. I hope you enjoy the presentation, and if you have any questions, please feel free to email me. There's absolutely one required reading, and I've attached it to this presentation, and you can find it under the paperclip icon as a PDF file. Chapter 25, Splenectomy, from the American College of Surgeons textbook Surgery, explains the anatomy, pathology, as well as surgical treatment for a variety of splenic disorders. This is required reading, and exam questions will come from this chapter as well as from this presentation. The other references I've listed for recommended readings. In addition to the recommended readings, this presentation, as usual, includes several videos. Most of the videos are included not to show you the surgical anatomy, but to show you the pathology and gross anatomy of the spleen. Multiple links have been placed to YouTube files which I've cut from my own personal collections and posted on YouTube to show the various anatomical variations of the spleen and the embryological consequences of portal hypertension. Please avail yourself of the opportunity to review these videos, especially Dr. Ackland's Video Atlas of Human Anatomy. I've also posted that for your review too. As you go forward in your clinical years, you'll need an anatomy book that pulls together not only the clinical relevance of the gross anatomy, but the radiological significance. Netter's Clinical Anatomy 2nd edition by Dr. John Hansen is that textbook. If you don't own a copy, sometime before you graduate, you probably should purchase this. At the conclusion of this presentation, you should be able to discuss the relevant embryology of the spleen, as well as to describe the difference between an accessory spleen and splenosis. You should also be able to describe the spleen's similarity to a lymph node, and of course discuss the gross anatomy and function of the spleen in the immunological system. We'll also introduce you to some cross-sectional anatomy on CT scans, MRIs, and ultrasounds by reviewing some images from the VH dissector, and you should be able to list several pathologies of the spleen. Portal hypertension is also discussed, along with the pathogenesis of splenomegaly and how a transjugular intrahepatic portosystemic shunt is useful. In anticipation of a surgical rotation where you might actually scrub in on a splenectomy, you should be able to briefly describe that procedure, as well as the 5 grades of splenic trauma which could lead to a splenectomy. Also list the 3 immunizations which are recommended either before or after a splenectomy is anticipated. And a brief introduction to overwhelming post-splenectomy infection is also introduced. In this presentation, we're going to discuss the embryology, the histology, the gross anatomy, which will include the arterial supply and the venous return of the spleen. Also briefly discussed is the lymphatics and the innervation of the spleen. As I've already mentioned, this is an all-inclusive presentation, which will include not only the embryology, but some radiology, cross-sections, and surgical videos, as well as a video by Dr. Ackland. Radiographs and cross-sectional images will be reviewed. We'll talk about splenography, or a partial splenectomy, as well as a complete splenectomy. And some of the pathology will include splenosis, splenomegaly, splenic cyst, portal hypertension, trauma, and overwhelming post-splenectomy infection. Functionally, the spleen is most similar to a large lymph node. This is a very simplistic view. However, it's important in the proliferation of lymphocytes, both T lymphocytes and B lymphocytes. It filters the blood and removes old and damaged red blood cells and platelets, which also allows it to recycle iron. It can, in some mammals, such as horses, serve as a reservoir for blood, and early on in fetal life, serve for hematopoiesis. Let's discuss some of the relevant embryology of the spleen. In this image, can you identify some vascular anatomy, and also, what have I circled? The spleen forms in the dorsal mesentery. The dorsal mesentery is home to the vessels which will eventually supply the blood supply to the gut. In these images, we see how the yolk sac begins to involute and forms the gut and the coelomic cavity. Remember, the spleen forms in the dorsal mesentery. That's where the large red arrow is located on this slide. In this slide, the large red arrow is pointing to the dorsal mesogastrium, right behind the stomach. This, in the embryo, is where the spleen will form. Here's a sagittal image of the previous slide. Notice the large red arrow in diagram A. That's where the spleen will begin to form, in the dorsal mesogastrium. In this image, we're actually looking at the posterior duodenum and the retroperitoneum near the head of the pancreas. As the dorsal mesogastrium begins to rotate, the pancreas and duodenum will become retroperitoneal structures. It's in this area of the dorsal mesogastrium that the parenchyma of the spleen begins to form. As the dorsal mesogastrium begins to rotate to the left, the anterior mesogastrium begins to rotate to the right. The large red arrow shows us where the spleen would be, and the small vacuoles in image A are actually small pieces of splenic tissue which coalesce to form the spleen. If they don't completely coalesce, they form small accessory spleens. We'll talk about that in a second. It's this rotation of the dorsal mesogastrium and the anterior mesogastrium which causes the vagus nerves to rotate. The left vagus nerve becomes the anterior vagus, and the right vagus nerve becomes the posterior vagus. Now we're actually beginning to see the spleen form in the dorsal mesogastrium. And as the dorsal mesogastrium rotates, it's beginning to form the ligaments of the spleen. Here we can see the ligament between the stomach and the spleen, called the gastrolienal ligament, and the ligament in the retroperitoneum, called the lieno-renal ligament, or the splenorenal ligament. These are noted by the large yellow and green arrows, respectively. It's also in this dorsal mesentery, the dorsal mesogastrium and the dorsal mesoduodenum, that the blood supply begins to form. Note the celiac artery and how it begins to form a blood supply to the stomach, to the liver, and to the spleen. The celiac artery, which begins to form in the dorsal mesogastrium, forms in the same region as the spleen. This will all make sense when we take a look later at some of the anatomy from Rowan's Atlas. Here's the same thing, just in 3 dimensions. Note the spleen and the dorsal mesogastrium, and how it begins to rotate and form the ligaments between the spleen and the retroperitoneum. Even though it's called the lieno-renal ligament, it's not really connected to the kidney proper. It's mostly just a ligament, a thin connective tissue sheath encompassing the spleen and joining the spleen to the retroperitoneum. The same is true of the ligament joining the stomach and the spleen, the gastrosplenic ligament. We'll look at these closer in just a minute. Just another 3-dimensional view of what we've already spoken about. Here we can see the spleen in the dorsal mesogastrium getting its blood supply from the celiac trunk. Also in the dorsal mesogastrium is the dorsal pancreas and the mesoduodenum. If you can understand the rotation of the anterior mesentery and the posterior mesentery, it'll soon make sense how the structures begin to lie in the abdomen proper. In this slide, we see the rotation of the dorsal mesogastrium and the rotation of the anterior mesogastrium. Note how the stomach begins to lay in the left upper quadrant along with the spleen, the formation of the ligaments between the spleen and the stomach, and also how the rightward swinging of the pancreas and duodenum will make these structures lie in the right side of the abdomen and in a retroperitoneal position. The long arrow crossing over the stomach, showing the rotational axes, also shows us the development of the omental bursa, or the foramen of Winslow. If you remember, this is where the Pringle maneuver can be performed, compressing the portal vein along with the hepatic artery and the bile duct in a surgical operation. Now let's talk about some of the histology of the spleen. Here's a spleen that's been cut in half. You can see the obvious red pulp and the white pulp. The white pulp is abnormal in this spleen. This spleen probably comes from a person who had lymphoma or leukemia. But keep the picture in mind, because under the microscope, the red pulp and the white pulp, along with the trabecula and the venous sinuses, become very important to the function of the spleen. Let's move on to the histology. Under the microscope, on an H&E stain, the red pulp stains pink and the white pulp stains purple. Let's look at these under higher magnification. Here, under higher magnification, through a slice of the spleen, we can see the capsule, which is very thin. At surgery, it tears very easily and bleeds extensively. The trabecula, noted by the letter T, is the framework of the spleen. It consists of reticulin fibers, and in some animals contains smooth muscle, which can cause the spleen to contract and force more red blood cells into the circulation. However, in humans, there are very few smooth muscle cells, and as such, the spleen does not act like a reservoir in the human like it would the horse. The red pulp is mostly vascular tissue, and the white pulp consists of T cells. In the spleen, something known as the periarteriolar lymphatic sheath, or a PALS, is noted by the central white pulp, the germinal centers. We'll take a look at this in a second. Here in this cross-sectional image on an H&E stain, we can see the periarteriolar lymphatic sheath. In the center, labeled A, is an arteriole, surrounded by lymphoid tissue and red pulp. Around the arteriole are multiple lymphocytes. Closer to the arteriole, these are differentiated into B lymphocytes, and more lateral are T lymphocytes. Hence, we believe that near the artery, the B cells differentiate and form immunoglobulins and antibodies, and more in the periphery of the germinal center are the T cells, noted for their function in cell-mediated immunity. Special stains are required to differentiate the T cells from the B cells. If we back off the magnification a little bit, we can see the germinal center. This looks a lot like the center of a lymph node. Lymph nodes have germinal centers too. The mantle zone and the marginal zone can be seen. The mantle zone is mostly the B lymphocytes. The marginal zone is mostly T lymphocytes, and of course the red pulp in the periphery is where the red cells are filtered. We'll look at this closer in a second. As the spleen becomes recruited to help in an antibody response or a cell-mediated response, it's believed that the arteriole begins to move towards the periphery. Here we can see the periarteriolar lymphatic sheath, but the artery isn't exactly in the center of the white pulp. Rather, it's pushed towards the periphery. In this individual, the splenic capsule is a little thicker. The trabeculin fibers, which make up the supporting network of the spleen, can be seen. But in this case, because the arteriole is more towards the periphery, this patient probably has been recruiting T cells to help with an immune response. If we back off the magnification and look at this cartoon of the spleen, we can see the trabecular network, which forms the framework of the spleen and how it's connected to the capsule. Of course, you can also see the germinal centers and the trabecular veins. The question becomes, if red cells flow into the spleen, how do they become filtered? How do they pass from the splenic artery into the filtering of the red pulp and back into the trabecular veins and out through the splenic vein. This circulation is very complex and for years was considered to be either an open or a closed circulation. We'll look at the two in just a second. So here's the age-old question. Does blood pass from the arteriole into a network of spaces in the red pulp or the splenic cords before entering the venous sinuses, passing through small slits in the walls of the venous sinuses? Or does it pass directly from the arterioles and their terminal capillaries directly into the venous sinuses? And if it is a closed circulation, how does the blood actually get filtered? We'll talk about this in a second, and then I'll explain why we actually care. This cartoon puts it all in perspective. Notice from the hilum, blood coming into the splenic artery, and then a branch called a trabecular artery, flowing around the germinal center where it can pick up antibodies or immunoglobulins. And then the red cells can eventually go out from the peninsillary arterioles and across the red pulp where the red cells are filtered into the venous sinusoids and out the trabecular vein. Notice the red arrow. This is where the question comes. Is this an open or a closed circulation? Do the red cells flow into the red pulp and get filtered, or does the peninsillary arteriole connect directly with the venous sinusoid? I will mention that the central artery and the peninsillary arterioles are all believed to be end arteries, just like what you have in your coronary arteries, the kidneys, and also your retina. But if these are end arteries, it doesn't explain how the blood gets filtered. Take a second and notice the two labels on this slide over to the left, where it says closed circulation and open circulation. If the spleen has closed circulation, the red blood cells will flow directly into the venules and back into the circulation. If it's an open circulation, they'll pass through the red pulp, get filtered, and enter a cell called a stave cell, S-T-A-V-E. We now know that the spleen mostly has open circulation. And here's how we know this. Blood comes in through the splenic artery, flows down a central arteriole of the periarteriolar lymphatic sheath, and then exits through peninsillary arteries, arteries that form at right angles through the central arteriole. They then move into the sheathed capillary. There's no endothelial lining here, but they're surrounded by macrophages. Eventually, once they've exited out the sheathed capillaries, they go through the red pulp where they are filtered and then enter back into venous sinusoids and back into the splenic vein. In a landmark paper using three-dimensional imagery and electron microscopy, this was put to rest. The human splenic red pulp harbors an entirely open circulatory system. Thus, the spleen is the only human organ where blood passes through spaces that are not lined by endothelia or other barrier-forming cells. In the previous slide, the question was whether they pass through a stave cell or they actually exit the endothelia through small spaces. This paper tells us that all of that was wrong. Actually, it's a completely open circulation and they pass through spaces that are not lined by endothelia. Why do we care? Because if we can make new drugs small enough to pass through these small spaces, we can treat cancers, lymphomas, and leukemias by concentrating our medications in the spleen. As mentioned earlier, and very simplistically, the spleen can be considered a very large lymph node, or an encapsulated mass of vascular and lymphoid tissue, as Gray's Anatomy puts it. Accessory spleens, which you should now understand from your embryology, can also form. These accessory spleens are usually joined to the splenic artery and vein by a thin band of vascular tissue. However, if someone has trauma to the spleen and small pieces of spleen break off and go into the circulation, splenosis can develop. I'll show you pictures of this in a minute. Fully functional splenic tissue is usually found within the gastrosplenic ligament and the greater omentum. From embryology, this will make sense. Here are images of spiniculi, or what's called splenosis. We actually can see small, tiny spleens, which are in the omentum, and in the picture in the lower left, you can see a small band of tissue connecting this small spleen to the omentum. This one is probably an accessory spleen and not truly splenosis, whereas in the other images, where the small splenic tissue is actually stuck to the omentum or the fatty tissue, those would be true evidence of splenosis. Again, the picture in the lower left is probably an accessory spleen because it has a fully functioning tiny branch of the splenic artery and vein connecting it. Most of the accessory spleens, those that actually form in the dorsal mesogastrium, are located where you'd expect them to be based on the embryology. 54% occur near the hilum of the spleen, 25% near the pedicle of the spleen, 6% near the tail of the pancreas, and of course several form in the greater omentum, the mesentery, and the ligament between the spleen and the colon. This makes sense if you understand the splenic embryology and how it forms in the dorsal mesogastrium. Again, this is an accessory spleen. Splenosis can occur anywhere in the abdominal cavity because splenosis is a result of splenic trauma. Also, it makes sense to understand that the pancreas, which is retroperitoneal, would lie in the splenorenal ligament. If you remember, when this ligament forms, it's actually not directly between the kidney proper and the spleen. It's between the spleen and the retroperitoneal lining. Hence, this is where the pancreas lies too. The spleen is almost completely covered by peritoneum, which is adherent to the capsule. However, it does remain connected to the posterior abdominal wall by the ligament between the spleen and the kidney, between the anterior abdominal wall, between the diaphragm and the colon, i.e. the phrenico-colic ligament, and it's connected to the stomach by the gastrosplenic ligament. Interestingly, because of the way the spleen forms, and it's covered entirely by peritoneum, one could argue that the spleen is actually retroperitoneal but intra-abdominal. However, we usually consider it as an intraperitoneal organ. Again, related to the embryology, the main splenic vessels lie between the two layers of the splenorenal ligament. Again, this makes sense because the spleen forms in the dorsal mesogastrium, as does the celiac artery. The celiac artery joins the spleen at the hilum in the splenorenal ligament. However, the ligament between the stomach and the spleen contains small end arteries. These are called the short gastrics, and also a branch of the left gastroepiploic artery. These become important vessels in surgery because unchecked and if not sutured properly can cause extensive bleeding. So exactly where is the spleen? It's in the left upper quadrant. It lays posterior and it's protected by ribs. Let's take a look. Here's where the spleen is. It lays posterior to the mid-axillary line, high in the left upper quadrant of the abdomen, posteriorly, protected by ribs 7, 8, 9, 10, and portions of 11, although the floating ribs really don't provide that much protection. Here's the same view in a cadaver. This image is taken from Rowan's Atlas of Anatomy. Anteriorly and posteriorly are marked, and the spleen can be seen being protected by the ribs. This image, taken from Gray's Anatomy for Students, 2nd edition, shows the spleen and where it's located in the left upper quadrant. The tail of the pancreas sits near the hilum. The splenic flexure of the colon is, of course, directly adjacent to the inferior aspect of the spleen, joined to the diaphragm by the phrenicocholic ligament. And because the splenic capsule is so easily damaged in surgery when we perform colon surgery, taking down the phrenicocholic ligament, there's actually a separate code for surgeons to use in this maneuver. We actually get paid a little bit more by taking down the phrenicocholic ligament and not damaging the spleen. The purpose of this slide is to show you the various indentations in the spleen. The superior border, which is notched, is often related to the blood supply. We'll see this in a second. But you can see the various indentations on the spleen formed from the colon, the kidney, the pancreas, and the stomach. We've already mentioned these ligaments and how they form, but here they are again. There's a ligament between the spleen and the colon, the sustentaculum lenis, the phrenicocholic ligament, the phrenicosplenic ligament, the gastrosplenic ligament, which contains the short gastric arteries and a branch of the gastroepiploic artery, and the ligament between the spleen and the kidney, containing the tail of the pancreas and the main pancreatic vessels. There's also small vascular adhesions on the medial side of the spleen, usually between the omentum and other structures in the abdomen, called criminal folds. These are the ones that bleed like crazy if you tear them, because tearing the criminal folds will cause a rent in the splenic capsule. When performing a splenectomy, the surgeon has to remember that the pancreas lies within a centimeter of the spleen in almost 3/4 of our patients. If we clamp the vessels going to the spleen, we have to be careful not to clamp the tail of the pancreas. Otherwise, we could cut the pancreas and cause a pancreatic fistula or a pancreatic leak. Here we're just trying to show, again, on this image taken from Moore's Clinical Atlas of Anatomy, where the main vessels to the spleen are in relation to the ligaments. The splenorenal ligament contains the splenic artery and vein and the tail of the pancreas. And more anterior to this, in the gastrosplenic ligament, we find the short gastric vessels. These are the ones that are often missed in a splenectomy and can lead to prolonged bleeding. This image was taken from the American College of Surgeons textbook called Surgery, and it's just a three-dimensional view of the ligaments, which we didn't see in the previous slide. The spleen is in the posterior left upper quadrant, the colon sits below it, the tail of the pancreas sits in the hilum, and the main vessels of the spleen sit in the splenorenal ligament. It's just a three-dimensional image of what we've already seen. This slide only serves to reinforce the embryology which we've already spoken about. The dorsal mesogastrium has rotated to the left and is noted by the oval circle at the hilum of the spleen. The anterior mesogastrium has rotated to the right and has now formed an opening called the omental foramen, or the foramen of Winslow. At surgery, if massive bleeding is encountered from the hepatic portal vein or from the hepatic artery, the surgeon can put his fingers into the foramen of Winslow and compress the portal triad to stop bleeding temporarily. The red ellipse near the hilum of the spleen is where we put our clamps to perform a splenectomy and hopefully avoid the tail of the pancreas in doing so. We've seen the embryology of the celiac trunk. Now let's talk about the blood flow directly to the spleen through the splenic artery. The splenic artery is a branch of the celiac axis. The celiac trunk is the largest, but it's also the shortest branch of the abdominal aorta, and it contains 3 branches: the left gastric artery, the splenic artery, and the hepatic artery. Most notably is that each spleen has its own peculiar pattern of terminal arterial branches. We'll talk about this in just a second. The take-home message from this slide, though, is that you should know and memorize the 3 branches of the celiac trunk. As a general rule, the splenic artery arises from the celiac axis to the right of the midline, and thus, on its way to the spleen, must cross the aorta. This can make angiography more difficult. Here we see the celiac trunk and its branches. The celiac trunk is denoted by the red arrow and is rather short. The splenic artery is long and tortuous and goes to the spleen. It's denoted by the yellow arrow. The green arrow is the left gastric, and the blue arrow is the hepatic. Notice in this image that the celiac is coming directly off of the aorta and its trunk is rather short. Also notice in this image that the splenic artery does not cross over the midline. The anatomy of the splenic artery is usually divided into two different varieties, the distributed form and the bundled form. We'll look at a picture of both in just a second. The distributed form refers to the fact that the splenic artery branches out and enters the hilum over a wide distance of the spleen, covering about 75% of the medial surface. The splenic artery proper is usually rather short and begins to branch rather early, sending several vessels to the hilum of the spleen. Interestingly, this is considered to be, at least for laparoscopic purposes, an easier dissection because each small branch of the splenic artery, in a distributed fashion, is separated from its neighbor by up to a centimeter. This makes for an easier dissection should the surgeon decide to ligate individual splenic branches. We'll see, however, that in terms of performing a splenectomy, because the vessels are spread over the hilum, it actually is more difficult of a dissection to remove the spleen in a distributed fashion over the bundled. This will be much clearer when we look at a picture of it. The other type of splenic artery anatomy is called bundled. This is where the splenic artery is rather long and divides near the hilum. The effect of this is that there are only 3 or 4 very large but short terminal branches entering the medial aspect of the spleen at the hilum, covering only about 25% of the medial surface. If a surgeon desires to dissect out each individual branch of the splenic artery, it's more difficult because the arteries are bundled together. However, in terms of performing a laparoscopic excision and transecting the artery at the hilum, it's much easier. Again, much more clear when we take a look at the image. Here we see the two different types of splenic artery anatomy. In the distributed splenic artery anatomy, we notice that the splenic artery is rather short compared to that of the bundled. The artery begins to branch much earlier and gives off a main artery to the pancreas, called the pancreatica magna. The splenic artery branches early and covers most of the entire medial surface of the spleen. Compared to the bundled, the splenic artery is rather long and only begins to branch about a centimeter away from the spleen. And when it does, it only covers about 30% of the medial aspect of the splenic anatomy. So if you're a surgeon and you want to take out only a portion of the spleen, it would be easier for you to dissect the individual branches away from the distributed type of anatomy. Whereas if you want to perform a splenectomy, you would hope your spleen would have a bundled anatomy, because one clamp across the distal splenic artery would allow you to control all of the vasculature, both arterial and venous, to the spleen, making for a splenectomy easier. Here's an example of the bundled arterial distribution going to a spleen. You can see the long, tortuous splenic artery to the left, and it begins to branch about a centimeter away from the hilum of the spleen, giving off multiple short branches, which cover only, in this case, about 40% of the splenic surface at the hilum. So, from a surgeon's point of view, it's much easier to clamp the distal splenic artery at one time to perform a complete splenectomy. And you can see dividing each individual branch of this bundled anatomy could be very tedious. Also note in this image that the artery is traveling through a ligament. And we know from the previous slides that this ligament is the ligament between the spleen and the posterior peritoneum overriding the kidney, the splenorenal ligament. Here in this image, below the splenic artery, you can also see a remnant of the pancreas. The pancreatic tail nestles itself right up into the hilum of the spleen. The surgeon must always be cognizant of the anatomical relationships of the pancreas to the spleen, the colon to the spleen, and the stomach to the spleen, because if a splenectomy is performed in a trauma situation or electively, any of these organs can be damaged. But in spite of trying to teach you the bundled versus the distributed splenic artery anatomy, the truth is that no two spleens have the same anatomy. There are collaterals which come off of the splenic artery at 90 degrees. This makes it very difficult for an interventional radiologist to try to embolize the splenic artery to keep it from bleeding. The most important aberrant branch, however, is the pancreatica magna. An occlusion of this vessel can cause pancreatitis or even necrosis of the pancreas. Go back and look at the previous slides to find the pancreatica magna, and it'll make sense. Remember, collaterals coming off at 90 degrees from the splenic artery make controlling any bleeding very difficult. Again, perhaps even more frustrating is the fact that branches from the splenic artery can be as few as 6 or as many as 36. This is important because if you're a surgeon and you're trying to perform a laparoscopic splenography, you don't want to dissect out 36 different branches and clip them. That could take all day. There does not appear to be any relationship to the size of the spleen and the number of splenic artery branches. So a very large spleen could have a bundled distribution, and a very small spleen could have a distributed distribution. But there may be some correlation with the presence of the notches or tubercles which are seen on the medial aspect of the spleen. In a patient with very large splenomegaly, sometimes these tubercles or notches on the medial aspect of the spleen can be palpated, especially if the patient is very thin. Without trying to get into too much detail, we try to break down the branches of the splenic artery into a superior, medial, and inferior terminal branches. And of course, each of these can have further branches. The important point is that the short gastric vessels, which we know come between the ligament joining the stomach and the spleen, the gastrosplenic ligament, can be easily torn during a laparoscopic Nissen fundoplication. That's an operation used to treat reflux disease. The inferior terminal gives off branches known as the inferior polar and also branches to the left gastroepiploic, which provides collateral circulation to the stomach. Most importantly is that the splenic artery usually gives off these three branches: a superior terminal, a medial terminal, and an inferior terminal. The rest is minutia. This slide, which comes from the American College of Surgeons textbook called Surgery, tries to break down the branches of the splenic artery so that it makes more sense. In reality, what's most important is that the splenic artery gives off a superior terminal, an inferior terminal, and a medial terminal artery. And the superior terminal gives off branches of the short gastric vessels. The medial terminal artery gives off those branches which go into the hilum of the spleen and directly into the body of the spleen. And the inferior terminal artery gives off branches to the left gastroepiploic artery. Here's an image from Moore's Essential Clinical Anatomy. Here we see the splenic artery ending into the spleen in a distributed fashion. The first large branch going to the pancreas directly off the splenic artery is the pancreatica magna. We also see the celiac trunk, which is very short, giving off the common hepatic artery, the left gastric artery, and the splenic artery. Below the celiac axis, coming from beneath the pancreas, is the superior mesenteric artery. Here's that same anatomy seen in a cadaver specimen. The red arrow shows the splenic artery. It can be recognized by its tortuosity. The blue arrow is a splenic vein. Both of these structures lie on the posterior aspect of the pancreas and usually arise from the posterior superior aspect of the pancreas. The superior mesenteric artery is seen beneath the medial body of the pancreas, and the C-loop of the duodenum can also be seen. Note the relationship of the pancreas, the duodenum, and the superior mesenteric artery. If branches of the splenic artery are selectively ligated or are subjected to an embolism, or from an interventional radiologist attempt at embolectomy for a bleeding spleen from trauma, this can result. This is called a splenic infarct. The yellowish areas represent those pieces of the splenic tissue which were supplied by an end artery branch of the splenic artery and have now caused an infarct into the spleen. Now let's take a minute to look at the venous return of blood from the spleen back into the hepatic portal circulation. It usually mimics and travels along with the branches of the splenic artery. Note, however, that the hepatic portal vein is a direct branch of the superior mesenteric vein. The superior mesenteric vein drains blood from the small bowel and the right colon up to the middle portion of the transverse colon. Blood from the small bowel enters the hepatic portal vein. Blood from the large bowel, from the splenic flexure and the descending colon, enter back into the venous circulation through the inferior mesenteric vein. The inferior mesenteric vein usually anastomoses with the splenic vein. And of course, we see short gastric veins, pancreatic veins. This anatomy is most important because the superior mesenteric vein, along with the splenic vein and the inferior mesenteric vein, which drains the blood from the small bowel, large bowel, and spleen, all return blood back to the liver via the hepatic portal vein. Here's a CT of the splenic vein where it's going into the hepatic portal vein. We'll see images of this later. So here's another image of the venous return from the spleen. Note that the splenic vein anastomoses with the inferior mesenteric vein, which returns blood from the splenic flexure of the colon and the descending and sigmoid colon, and then it forms with the superior mesenteric vein, draining blood from the small intestine, the right colon, and the hepatic flexure of the colon back into the hepatic portal vein. Remember, blood flow to the liver is about 70% from the hepatic portal vein and about 30% from the hepatic artery. Anatomy of the spleen isn't complete until we mention some of the lymphatic flow. Most of the lymphatics of the spleen and the lymph nodes of the spleen can be found near the hilum. There are also lymph nodes along the superior border of the pancreas, and there are several lymph nodes surrounding not only the celiac trunk, but the superior mesenteric artery. In this image, taken from Moore's Essential Clinical Anatomy, the green arrows show the flow of lymph back into the lymphatic circulation. In humans, innervation of the spleen is not actually that important. The spleen in humans is innervated by a parasympathetic branch of the vagus nerve, and also from branches from the celiac ganglion and from the superior mesenteric ganglion. Most of the spleen, however, is controlled by noradrenergic receptors. It's this sympathetic inflow to the spleen that in times of trauma or fight or flight response allows the spleen to contract, releasing its blood flow back into the circulation. In horses, that's important, but in humans, we don't have that much smooth muscle in the spleen, and therefore such innervation is not that important, and the return and release of blood flow from a spleen trying to contract is not that important in humans. In the next slide, We'll see Dr. Acklin review all of this anatomy in a fresh cadaver. Take 8 minutes out of your life to watch this brief video by Dr. Acklin. I've posted this on YouTube so it doesn't take up a lot of room in the presentation. Dr. Acklin reviews all of the anatomy of the spleen as well as the anatomy of the celiac axis. I think you'll enjoy it, and it's pretty quick. Now that we've gone through the histology, embryology, and gross anatomy of the spleen, let's take a look at how you're actually going to see it as a clinician, and that is in cross-sections, on CT scans and MRIs, and also ultrasound. Orient yourself with this image. Here we can see the spleen, the stomach, the colon, the portal vein, and the liver. The fat surrounding the stomach, colon, and spleen has been highlighted with a purplish color. The small, short gastric arteries can be seen as tiny black dots between the spleen and the stomach. In this image, the splenic artery is labeled with the red arrow. The splenic vein is seen with the blue arrow. The remaining structures, the spleen proper, as well as branches of the splenic vein going into the hilum of the spleen, can be seen along with small bowel, pancreas, stomach, and the green arrow shows us the duodenum. The liver is also marked. In this image, we've drawn attention to the splenic artery. Note that the artery, which is very tortuous, lies on the posterior aspect of the pancreas. And directly anterior to the artery is a black structure, which is the splenic vein. Also note the spleen, the colon, jejunum, stomach, and liver. After you've studied the previous cross-sections from the Visible Human Project, now take a look at this CAT scan. You should easily see the liver, the pancreas, the spleen, the left kidney, the upper portion of the right kidney, and even the aorta, and you can even see the portal vein. The red arrow is showing us the ligament between the posterior retroperitoneum covering the kidney and the spleen proper. This ligament is called the splenorenal ligament. Here's some more cross-sections for your practice. The blue arrow is showing branches of the splenic vein. The pancreas has been labeled, the inferior vena cava, the hepatic portal vein, and by now you should recognize small intestine, stomach, and duodenum. Practice on this CAT scan. Can you find the pancreas and the spleen? Can you also see the aorta and the inferior vena cava? What about the superior mesenteric vein? What about the portal vein? The stomach and the liver, the kidney, colon, all of this can be seen in this image. Take a minute and contrast and compare this CT scan image with the previous images from VH Dissector to make sure that you can recognize the pertinent anatomy. Because as a clinician, this is how you're going to see your anatomy. Of course, in this image, I'd like you to be able to find the spleen and the splenic vein. The pancreas, the tail of the pancreas is nestled into the hilum of the spleen, the colon, the small bowel, and stomach. I've taken and placed a green arrow to show you how well you can actually see other structures. Adjacent to the hepatic portal vein and between the green arrow is the common bile duct. Below this is the inferior vena cava, and even in the retroperitoneum, and it's not labeled, is the aorta. See if you can find all of these structures. Here's another image to practice on. The technology is so good today that we can actually see blood mixing with the intravenous contrast in the inferior vena cava, noted by the blue arrow. Also in this image, we can see the spleen, the stomach filled with oral contrast, the left kidney, the aorta, probably the superior mesenteric artery with its associated branches. Remember, the celiac axis is usually very short. Here, the branch coming off the aorta, which makes me think it's the superior mesenteric artery, is elongated, probably 2 to 3 centimeters. That's most consistent with the SMA. You can also see the portal vein going into the liver. That's found just above the blue arrow. And then, of course, the inferior vena cava, where the whirl of contrast is seen. Stop this presentation for a second. Quiz yourself to make sure that you can identify all of these structures. Find the stomach, the kidney, the splenic vein, the aorta, the vena cava, the hepatic portal vein, and the celiac axis. In this image, the red arrow shows us the celiac axis, and the blue arrow shows the right gastric vein. Also noted is the left kidney, the spleen, the colon. You should be able to identify not only the liver and small bowel, but the adrenal glands, both of which are visible here. And you should be able to identify the retroperitoneum, most notably the ligament between the spleen and the kidney, known as the splenorenal ligament, which is clearly seen here. Try to identify, by covering up the structures, each of the following: the inferior vena cava, the aorta, the splenic vein, the celiac axis, the hepatic portal vein, the right gastric vein, the small bowel, the colon, the spleen, the left and right kidneys, the adrenal glands, and, of course, the diaphragm. Here's another cross-section of the spleen, but this time it's on an ultrasound. Noted is the hilum and the spleen itself. Let's take a look at some more images. Here we see the spleen and hilum, and the blue arrow shows us the diaphragm, separating the thorax from the abdominal cavity. Such a view becomes important because today in emergency rooms, ultrasound is often used to assess for splenic trauma or blood in the peritoneal cavity. It's quicker than getting a CAT scan. In the event that this patient had a ruptured spleen, we might be able to actually see the spleen and the transection of the capsule or a rupture of the parenchyma, but we probably would be able to see fluid, and that would be seen by increasing the distance between the thorax and the spleen, where the diaphragm is located. We'd see a pool of blood underneath that white shiny line where the blue arrow is at. Another cross-sectional image. Here we see the spleen and left kidney. We cannot clearly see the diaphragm or the thorax in this image. Before we can talk about splenomegaly, we need to discuss one of the common conditions which can lead to splenomegaly, and that is portal hypertension. Portal hypertension is a condition in which the liver, usually by cirrhosis, becomes so contracted, scarred, and inflamed that the usual blood flow to the liver can't get through. This causes a backup and a buildup of the pressure in the portal system, the portal vein and the splenic veins, as well as the coronary veins. Here we see an image of the liver, which is shrunken and cirrhotic, leading to not only esophageal varices, but also to gastric varices via the splenic vein. The treatment for gastric varices, which is diagnosed on upper endoscopy, is to perform splenectomy. The treatment for esophageal varices, which can cause upper gastrointestinal bleeding in a patient who has significant cirrhosis, is to perform endoscopic sclerotherapy or rubber band therapy, where small rubber bands are placed around the bleeding esophageal varices. In many patients, it's a mortal condition. In this image, we can also see that the patient has a shunt, a transhepatic portosystemic shunt. We'll talk about that in just a minute. It's a way of causing blood to bypass the cirrhotic liver and decompress the high venous pressures within the portal system. We'll get there in just a second. This patient has severe portal hypertension. We note the abdominal wall varices and also the gynecomastia. In a patient with this degree of liver dysfunction, probably from cirrhosis, the liver is unable to convert the body's estrogens into testosterone. As such, the excess estrogens build up, causing gynecomastia. The estrogens also soften the body tissues, leading to smooth skin and soft parenchyma of tissues, leading to abdominal wall hernias. The caput medusa, which is pronounced here and is seen as varices of the abdominal wall, most specifically varices of the epigastric veins, come as collateral circulation from the femoral veins. At the end of this presentation, I've included several PDF files of chapters and one article to read about portal hypertension. I hope you find them useful. One is a classic historical paper from the 1950s describing a patient who had multiple operations for bleeding varices. This patient most likely has end-stage liver disease, and we are looking at the results of this. The patient has an umbilical hernia from the tense abdominal ascites and most likely from the excess estrogens which have softened the tissues. The patient also has a caput medusa, a result of collateral blood flow around a cirrhotic liver. Most likely this patient has splenomegaly and a coagulopathy. Here's an image of a transjugular intrahepatic portosystemic shunt in a cirrhotic liver, joining the hepatic vein to the portal vein. In order to understand how splenomegaly can form as a result of a cirrhotic liver, we need to review first some embryology and the fetal circulation. We'll do that next before we look at a video of portal hypertension. Here we're going to review the fetal circulation. The two paired umbilical arteries, which are branches of the internal iliac arteries, carry deoxygenated blood in the fetus back to the placenta. Then it becomes oxygenated and returns back to the fetus through the umbilical vein, bypassing the liver through the round ligament and eventually through the ligamentum teres. After the baby is born, the umbilical arteries turn into medial umbilical ligaments. They don't recanalize because they're arterial and not venous structures. However, the umbilical vein, which previously carried oxygenated blood, now traverses through the round ligament and through the falciform ligament of the liver, eventually flowing through the liver and going into the main circulation through the ductum venosum, which becomes the obliterated ductus venosus. It's these embryological remnants which become recanalized. We'll see a video where the round ligament, traversing through the falciform ligament between the right and left lobes of the liver, becomes greatly engorged as it acts as collateral circulation around a cirrhotic liver. This is the beginning of portal hypertension. Let's take a look. Remember, the umbilical arteries become the medial umbilical ligaments. They don't recanalize, but the umbilical vein becomes the round ligament, and in the video is clearly seen traversing through the falciform ligament. We can't see the ligamentum venosum, which was the old ductus venosus, but it's there and most likely it's recanalized too. Here we're looking at the posterior aspect of the anterior abdominal wall. The blue arrow is showing the inferior epigastric vein. This vein becomes engorged in a patient who has severe portal hypertension. The red arrow is showing the old umbilical artery, now appearing as the medial umbilical fold. This umbilical artery does not recanalize in portal hypertension because it truly was an arterial structure and not involved in the excess pressures of the portal venous system. In an effort to reinforce the embryological anatomy that you have just heard and how that shows up in a patient with portal hypertension, let's take a look at one of my patients who suffered with symptomatic gallstones, i.e. cholelithiasis, and severe cirrhosis. You'll see the shrunken, scarred liver, as well as a dilated round ligament and inferior epigastric vein. All of these dilated because of the increased pressure in the portal venous system. Take a look at the video. It's about 7 minutes long, and this will reinforce why patients with cirrhosis get portal hypertension and how the embryology becomes important. The severe portal hypertension, which results in a patient who has underlying cirrhotic liver disease and the underlying splenomegaly, is often surgically addressed by performing portosystemic shunts. In the 1960s and 70s, these were common operations, but are rarely performed today. They've been replaced with a procedure called a TIPS, T-I-P-S, We'll look at that in just a minute. A portosystemic shunt, the most famous, was the distal splenal renal shunt, or the Warren shunt, was a method whereby the portal vein was anastomosed to the inferior vena cava, the portal circulation to the systemic circulation. This was done to address the congestion caused by a cirrhotic, swollen, shrunken liver. Of course, the mortality and morbidities were very high. Patients usually have hepatic encephalopathy and have underlying thrombocytopenia, as well as disorders of their clotting cascade. It's a high morbid procedure and is rarely done today. Here's a procedure called a TIPS, a transjugular intrahepatic portosystemic shunt, performed by an interventional radiologist. Through the jugular vein, the interventional radiologist will thread a catheter down through the inferior vena cava, through the hepatic veins, and literally break apart an opening in the scarred cirrhotic liver and form an anastomosis using a shunt from the hepatic vein to the portal vein. This allows rapid decompression of portosystemic hypertension, allowing blood flow from the portal vein to readily bypass the liver parenchyma and flow into the hepatic vein. One of the side effects is an increase in hepatic encephalopathy, because we're basically bypassing the metabolic abilities of the liver to break down protein byproducts. This can lead to an excess in ammonia and an excess in hepatic encephalopathy. Here's the scheme for splenomegaly. We've pretty much covered the hepatic cause for splenomegaly, and that is cirrhosis. A prominent infectious etiology of splenomegaly is mononucleosis, and we've briefly mentioned a malignant cause of splenomegaly, i.e. lymphoma. Congestive heart failure can also lead to splenomegaly. Other lectures will cover metabolic and infiltrative disorders of splenomegaly. In this image, we see an enlarged spleen from spherocytosis. The red arrow is showing the hilum of the spleen, containing the splenic vessels, both the artery and the vein, which are very prominent and enlarged in this photo. Splenomegaly is rated according to the size of the spleen. You don't need to memorize this. Just know that a normal spleen is about the size of your fist, whereas a megaspleen can be greater than 30 centimeters and more than 3 kilograms. Other splenic sizes rated as moderate splenomegaly and severe splenomegaly will help the surgeon determine what type of operative procedure is needed to remove the spleen. Megaspleens are removed via an open approach instead of a laparoscopic approach. Megaspleen is greater than 30 centimeters. Massive splenomegaly is bigger than 20 centimeters but less than 30. A normal spleen is less than 11 centimeters, and a moderate splenomegaly is between 12 and 20. Again, you don't need to memorize this. Splenic length is usually measured using ultrasound and not CT scan. For comparison, look at the CAT scan showing splenomegaly compared to the normal spleen. Also note that in the image showing the enlarged spleen, that the liver is also very large. This patient has hepatosplenomegaly and probably underlying portal hypertension. You should be able to recognize in the CT scan on the lower right not only the spleen but the splenic vein, the left kidney, the stomach, the aorta, the adrenal gland, the hepatic portal vein, the inferior vena cava, and the liver, as well as the diaphragm. See if you can find and name all of these structures. Here's a megaspleen, and this was removed appropriately through a lower abdominal incision. The patient is placed flat in the operating room for this, and you'll review a video coming up of how a normal laparoscopic splenectomy is performed with the patient lying in a lateral position. That's not usually possible in a patient with splenomegaly of this size. Here is a megaspleen. This was removed appropriately through an open abdominal incision. One of the most common causes of splenectomy is automobile trauma, and of course penetrating trauma, in this case the horn of a bull. But in most large cities, stabbings and gunshot wounds lead to their fair share of splenectomies too. The purpose of this isn't to make you a surgeon, but it is to show you how a surgeon looks at splenic trauma and how we make the decision whether or not to remove the spleen and the relevant anatomy that we need to know in order to perform that procedure. The spleen is prone to rotational trauma because of an elongated hilum, mostly as a result of redundant splenic ligaments. In automobile accidents, the forward momentum of the automobile, and in a patient who's not wearing their seatbelt, also results in the forward momentum of the spleen, resulting in a shear or tear of the splenic capsule. Most of the time, however, we try to save the spleen. We sew it with Teflon pledgets. There's a slide of that coming up. And sometimes we'll put it in a bag of Vicryl or Dexon. This is what sutures are made of, and it absorbs with time. Most of the time, though, we resort to performing splenectomy. There are several grades of splenic trauma. You don't need to memorize this chart. And I'm going to show you various images coming up of splenic trauma of the various grade levels. It's subjective. It's not 100%. The most important one to know is that in grade 1 splenic trauma, you can look at the CAT scan, make sure that the patient is safe and stable, and probably go back to bed. A grade 5, however, which results in splenic lacerations through the hilum and a bleeding spleen from a shattered organ, means you'll probably end up going to the operating room. Let's take a look at the various grades. Here's an example of grade 1 splenic trauma. Here the spleen can be seen with a shattered capsule. There's no free blood in the abdomen, and the organ is basically still intact. Here's an example of grade 2, and I actually believe this to be a grade 3 splenic trauma. The red arrow shows blood around the spleen. There's a crack in the splenic capsule, and some of the spleen parenchyma is contused and broken. That's what makes me think that this is actually a grade 3 instead of a grade 2. Nevertheless, depending on how stable the patient is, you might be able to not operate on this patient, and they may be able to go home. But in doing so, we often put people on restrictions for up to 6 months while the spleen heals. Here's an example of grade 3 splenic trauma. The red arrow is showing the extravasation of intravenous contrast into the abdomen. In other words, this spleen is actively bleeding. Just lateral to that red arrow, you can see a crack in the upper pole of the spleen. The spleen is partially pulverized. And in addition, we can see contusions of the capsule in the right upper photograph. This leads us to think that this patient is actively bleeding. There's blood surrounding the spleen, and this patient will probably end up with a splenectomy. Truthfully, I don't see much difference between this grade 4 and the previous image on grade 3. The scale is very subjective, but this patient has active extravasation of contrast, seen by the downward pointing red arrow. The small white area is intravenous contrast leaking into the peritoneal cavity, and the horizontal red arrow shows a crack in the upper pole of the spleen, blood surrounding the spleen. In my opinion, this is a grade 4, and one could argue that in the previous slide that was a grade 4 instead of a grade 3. It's not a perfect measurement system. This patient will end up with a splenectomy. The spleen is pulverized, there are multiple fractures through the spleen, there's blood surrounding the organ, and the small blue arrow is showing extravasation of contrast around the splenic parenchyma. This patient will end up in the operating room. First off, you don't need to remember any of these names. I'll tell you when you need to remember a name. What's interesting is the fact that the mortality before the 1900s from a splenectomy was almost 90%. The second patient, from the surgeon O'Brien, performed a splenectomy on a patient who had raped a woman. The spleen was seen protruding from the wound. In typical poetic justice style, the patient died. Notice that in 1826, when anesthesia was used, the patient still died. Almost all of these patients die from an overwhelming post-splenectomy infection. Today, with antibiotics and vaccines, we almost never see this. Splenectomy performed in today's operating rooms results in a mortality of less than 1%. As already mentioned, splenectomy became more common because of automobile accidents in the 20th and 21st centuries. Overwhelming post-splenectomy infection, or OPSI as surgeons refer to it, led to the advent of partial splenectomies and attempts to save pieces of the spleen, known as splenosis. Here is a name that you'll need to remember, and that's Peon, P-E-A-N. In the 19th century, he performed a splenectomy after no one had tried it for almost 100 years. Toronto's Hospital for Sick Children began a study and came to the conclusion that non-operative treatment often worked for children, and because overwhelming post-splenectomy infection is more common in children, it turns out that by operating on the spleen, performing splenectomy on a child could lead to OPSI. Toronto's hospital set the standard for non-operative treatment in children for splenic trauma. Why do I ask you to remember Peon? Because when you do your surgical rotations, one of the large clamps that's used to clamp across vessels and usually the splenic hilum is called a Peon clamp. You'll be able to impress your surgical attending by telling him the history of the clamp that's used. That Dr. Peon was one of the first surgeons to perform a successful splenectomy. Depending on why the patient is actually presenting for a splenectomy, they may require preoperative evaluation and medications or blood products. For example, in a patient who has ITP, idiopathic thrombocytopenic purpura, these patients may require preoperative or intraoperative transfusion of platelets or cryoprecipitate, or even fresh frozen plasma. Some of these patients have presented on steroids and usually receive a preoperative stress dose of steroids as well as a postoperative steroid taper. Gamma globulin is also sometimes used. Most patients who present with a splenic trauma are healthy and will not require any of these. This picture makes a splenectomy look easy. The abdomen's wide open. The surgeon simply transects the lateral ligament holding the spleen to the diaphragm and lifts up the spleen to clamp it and remove it. It's not this easy. Once the spleen is removed, the patient can have several complications. Most notably, patients can get pneumonia of the left lower lobe of their lung, effusion, or even just simple atelectasis, which can lead to pneumonia. Sometimes they get a subphrenic fluid collection or abscess. There can also be inadvertent damage to the stomach and the colon, or even the pancreas. If the surgeon doesn't understand the anatomy and clamps the splenic hilum too proximal to the pancreas, a pancreatic fistula can result. Of course, most patients will have only a transient thrombocytosis, an elevation of the platelet count sometimes greater than 1 million. Splenic vein thrombosis and worse, portal vein thrombosis, which can be fatal, can also be complications of a splenectomy. And in children, overwhelming post-splenectomy sepsis or overwhelming post-splenectomy infection can occur, hence the reason for the push for non-operative trauma in children. But sometimes non-operative treatment fails and you need to remove the spleen. Patients in whom you anticipate performing a splenectomy or who've had splenectomies should receive all 3 of these vaccines: Haemophilus influenza, a meningococcal vaccine, and a pneumococcal vaccine. And probably every 10 years should be revaccinated. Please make it a point to check that all of your patients who present who've had splenectomies have had these 3 vaccines. And if they haven't, or they don't think they have, or you can't find the old records indicating that they've had these vaccines, it's probably a good idea to revaccinate them. Splenectomy, most notably in children, can lead to overwhelming post-splenectomy infection. In my 20 years as a surgeon, I actually never saw a case of OPSI. Splenectomy causes a reduced clearance of bacteria, a transient elevation in the platelet count, thrombocytosis. It also reduces intracellular antigens, such as that seen in malaria, and a decreased production of properdin and tufsin. These are tetrapeptides which are produced by the enzymatic cleavage of IgG. Tufsin is named because As you'd expect, it was found at Tufts University. The most common causes of overwhelming post-splenectomy infection are from strep pneumonia, Haemophilus influenza, Streptococcus, and Staph aureus. Of course, other encapsulated organisms can cause an overwhelming post-splenectomy infection. A patient who's had a splenectomy is unable to fight off these encapsulated bacteria, leading to multiple organ failure, shock, and disseminated intravascular coagulation. Overwhelming post-splenectomy infection is highest in children, of course, in those who suffer from a malignancy, and in immunocompromised patients, such as someone who's had chemotherapy or even HIV. The lowest risk occurs in our trauma patients who usually present and are normal, healthy adults. Spherocytosis, ITP, and incidental splenectomies that result from taking down the colon or the splenic flexure or from gastric surgery present the lowest risk for OPSI. Patients' highest risk is within 2 years of the splenectomy, and if they do get OPSI, which we rarely see today because of the vaccines, the mortality can be almost 70%. The lifetime risk is 1 to 5%, and patients, of course, should receive those vaccines. Here's a patient who the surgeon is attempting to create splenosis. They've removed the spleen, chopped it into rather large pieces, and sewn it into the omentum. I suspect that because of the large pieces of spleen that this surgeon has used, that these spleen segments won't develop a blood supply in time for this patient to develop splenosis. I think he would have done better to create smaller pieces of splenic tissue. Most likely in this patient, he'll end up with just 5 pieces of dead necrotic spleen. But nevertheless, it's an interesting image to try to show how surgeons attempt to save splenic function and to prevent overwhelming post-splenectomy infection in a patient. The advent of laparoscopic splenectomy began in the early 1990s. And an interesting quote, "Medicine is not an exact science, and nowhere is this observation more appropriate than in the operating room where a spleen is being removed. In fact, in my experience, sometimes it's comical. Sometimes the spleen is shattered and lifts right out. Other times you have to dig it out. Sometimes it's a bloody mess, and other times there's hardly any blood loss at all. It can be a very daunting task in the middle of the night, especially when one doesn't have an assistant. You don't need to remember the names of these surgeons. Just know that laparoscopic splenectomy is relatively recent." You've already seen cases of massive splenomegaly, where the patient had their spleen removed lying in the supine position flat on the operating room table. The lateral approach, with the patient lying in the operating room with his right side down, performed for a laparoscopic splenectomy, is usually reserved for smaller spleens that are more accessible. But remember, you might want to remind the surgeon that he doesn't need to charge in and remove the spleen. He should first make an attempt to look for any accessory spleens. Accessory spleens can cause the disease process to recur, especially if we're talking about ITP. When performing a laparoscopic splenectomy, the surgeon can hope for bundled arterial anatomy. That might make it easier for a linear stapler to be placed across the hilum to divide the vessels. It also will allow for some safety in dividing the tail of the pancreas to avoid a pancreatic fistula. When we take down the splenic flexure of the colon, i.e. the colon is suspended to the diaphragm by the phrenicocholic ligament, we usually take this down last because it helps to suspend the spleen and ease our visibility when we perform the laparoscopic procedure. The more widely distributed arterial anatomy is more appropriate for splenography, but again, the surgeon must be careful not to bag the artery going to the pancreas. A distributed arterial anatomy is more appropriate if the surgeon desires a splenography and tries to leave a portion of the spleen. A video of a splenography and a laparoscopic splenectomy is coming up. There are several contraindications to a laparoscopic splenectomy. Severe portal hypertension, i.e. a megaspleen or intra-abdominal ascites, or an uncorrectable coagulopathy with severe thrombocytopenia and a severe distortion of the clotting cascade are contraindications. Traumatic injuries can be a relative contraindication to a laparoscopic splenectomy, especially when the surgeon suspects other disorders and or damage. Extreme splenomegaly is a relative contraindication. Usually for the megaspleens, those are removed via an open approach. In the next slide, we briefly look at a laparoscopic splenectomy. Here's a link to a laparoscopic splenectomy, which I've edited down to about 2 minutes. I'm not trying to make you a surgeon, but what I am trying to show you is the anatomy as it actually looks like in a real breathing patient, not a cadaver. I want you to see how much anatomy you can recognize when the surgeon is performing the laparoscopic splenectomy. Here's a link to a laparoscopic splenectomy performed by a surgeon at UCSF. I have re-edited it and made as many notations as I can of the relevant clinical anatomy which I pointed out to you in this presentation. See if you can follow the anatomy as the surgeon points out the steps to performing the laparoscopic splenectomy. It's only about 5 minutes in length. A partial splenectomy, or a splenorrhaphy, can be performed for a variety of causes, including cyst and benign tumors. We'll look at a small video of a partial splenectomy being performed for a splenic cyst. It can also be performed for leukemia and lymphoma, for a single metastatic lesion to the spleen, thalassemia, spherocytosis, even trauma, where we can attempt to preserve splenic function, especially in children. But sometimes trauma is a contraindication to a laparoscopic procedure when other damage is suspected in the abdomen. Storage diseases such as Gaucher's disease can also be rectified by a partial splenectomy. Also, a partial splenectomy can be performed for the staging of Hodgkin's disease. This is rarely done anymore. In this operation, lymph nodes are sampled from various areas in the abdomen to assess whether the cancer has spread to lymph nodes above the diaphragm and or below the diaphragm to help stage how the radiation therapy is used to treat the Hodgkin's disease. This procedure is rarely, if ever, done anymore. Resolution on CAT scans has made this procedure, i.e. a staging laparoscopy or staging laparotomy, almost extinct. In this brief 3-minute video, you'll see a surgeon perform a splenorrhaphy, actually saving the spleen after resecting a benign cyst on the spleen. Again, it's not to make you a surgeon, but to show you what in situ anatomy looks like. See if you can take a look at this and figure out all of the relevant anatomy thus far. In an open approach, a partial splenectomy can be performed by placing sutures all the way through the spleen. In this picture, we see Teflon pledgets. Sometimes even Gore-Tex can be used to hold the sutures in place to keep them from tearing through the spleen. Even though this picture makes it look easy with the surgeon holding the spleen, remember, you're working in the left upper quadrant of the abdomen, shielded by the costal margin and posterior to the pancreas, colon, and stomach. In reality, a splenorrhaphy like this is actually pretty hard to do. So here's a short 1 minute and 40-second video on a laparoscopic removal of a cyst from a spleen. You should note that laparoscopic splenectomies or laparoscopic splenorrhaphies for cystic disease of the spleen is very common. Most cysts of the spleen are indeed benign, but over time can result in malignancy, especially if larger than 6 centimeters. The recommended follow-up for splenic cyst is every 6-month ultrasonography to assess the size of the splenic cyst, and if it encroaches 6 centimeters or larger, it should be removed, either with splenectomy or splenorrhaphy, to rule out the possibility of malignant transformation. Well, I know it's been a rocket ride and we've covered a lot of information, but I believe all of it's necessary for you to be able to understand the spleen, the pathology of the spleen, the embryology and histology of the spleen, as well as to be able to understand some basic radiographs and cross-sections. We've covered a lot of information, not only including overwhelming post-splenectomy infection, but the possibility of performing splenectomies and or splenorrhaphies. There's been a lot of information, and I appreciate your time and attention. Please remember to download the PDF files which are attached to the Adobe Presenter file under the paperclip icon. If you have any questions, please feel free to email me.